Good morning, my name is Eliana Bonfante. On this video I will be talking about interpretation tips for brain and neck CTA. This lecture is going to be divided in three sections. First, we're going to talk about the technique and the types of reformatted images that we are presented with. Then we're going to see examples on pathology, and on that we're going to see traumatic injuries and cerebrovascular disease, which is the vascular imaging that we do in patients with ischemic and hemorrhagic stroke. Lastly, we are going to summarize some interpretation tips. CTAs are acquired during the dynamic administration of iodinated contrast with thin collimation. In our institution, we use 1.5 millimeter. Then that information gets reformatted, and we use different sets of reformatted images. We use maximum intensity projection images, in which we take one voxel and only display the maximum density on that voxel. We also use multiplanar reformatted images, in which we display all the gamut of densities within each voxel. And we also have vessel tracking images, in which we track the contrast from the aortic arch to the intracranial portion of the vessels to have an elongated appearance of the vessels that are otherwise seen in multiple reformatted images. For those images, we also optimize the thickness of acquisition, and it's going to be different for the brain and for the neck. Let's see those examples. On the left side, we have the MIPS, whereas on the right side, we have the multiplanar reformatted images. So on the maximum intensity projection, we're going to have more images than on the MPR, and then I am going to scroll through them together, and you may notice that on the left side we can see a more extensive length of the artery than we can see on the right. On the other hand, if we were going to look at the details of the skull base segments of those internal carotid arteries, we would not be able to see those on that image, but on this one we can see each segment and we can distinguish them from the bone, the anterior clinoid processes adjacent to it. So basically we use the multiplanar reformatted images to see the detail on the skull base, and that's why those images are thin collimation 1.5 millimeter, and we use the MIPS to look at large segments of the vessels within the parenchyma. So when you're looking for narrowing like atherosclerosis, you're looking for bifurcations for aneurysms, you're looking for a branch occlusion for a stroke, this set of images is going to be more helpful. But if you're looking for a dissection near the skull base or an aneurysm in the cavernous segment of the internal carotid arteries, then the MPR images are more useful. Here we have an example of vessel tracking imaging, where our techs in the Center for Advanced Imaging Post-Processing do some reformatted images tracking the flow from the aortic arch to the intracranial portion of the vessel in comparison with the MIP. So notice that on the MIP images, the vessel is coming in and out of the plane in which we are imaging. So even though we have a very nice analysis of the contour of the vessel, we have to scroll back and forth to look at all the features of that vessel. Whereas on this reformatted image, we are focusing only on that artery and we are rotating it. So this is very useful to quantify narrowing at the carotid bulb, to see how much atherosclerosis there is in there, and it's also very useful to see contour abnormalities in the setting of traumatic vascular injury. CTA is used for the evaluation of cerebrovascular injury, and we use the classification of BIFL, also known as Denver, in which the degree of luminal narrowing is identified as less than 25% or more than 25%. We analyze the presence of pseudoaneurysm, occlusion, or transection with free extravasation. The UT group considers that this classification omits some important features in the classification of vascular injury, and they have requested that we analyze a few additional features. For locating the arteries, they use this classification of the location of the different segments of the carotid system and the vertebrovascular system, and then they want us to analyze the degree of stenosis in thirds, less than 1/3, between 1 and 2/3, and more than 2/3 for grades 1 through 3, occlusion for grade 4, and transection for grade 5. In addition to these features, they want us to comment on the presence or absence of pseudoaneurysm and intraluminal thrombosis. Here are some schemes that Dr. Gavito made for our group, grading 1 through 3, depending on the percent of occlusion, so the presence of pseudoaneurysm and intraluminal thrombosis, and then grades 4 and 5 for complete occlusion or extravasation. Here we have an example of grade 4 injury of the left vertebral artery. We start looking at the left vertebral artery at its origin with an atherosclerotic plaque from the subclavian artery. Please notice the density of the other 3 vessels, the 2 carotids and the right vertebral, is higher than the left vertebral artery. As we scroll up, that artery continues to decrease both in density and in caliber until it stops opacifying with contrast. More distally, at the level of the lateral mass of C1, we can see that that vessel is again opacified, likely in a retrograde fashion. When we look at the coronal reformatted image, we can see the plaque at the origin, the proximal cervical segment decreasing in caliber and density, and the occluded segment with the distal recanalization. This is an example of a patient with multiple traumatic vascular injuries, and the reason we have to be very careful scrolling through all of the vessels and don't have satisfaction of search. Let's focus on the right internal carotid artery. This is the distal segment, and we see that it's tortuous, but then it has an area of outpouching of the column of contrast with flattening of the outer margin. That is a grade 3 injury with a pseudoaneurysm. But if we go backwards on the right vertebral artery now, we can see that that artery is also abnormal with a filling defect that rotates and causes more than 25% stenosis, and therefore is a grade 2 vascular injury. The right vertebral artery has other areas of vascular injury more proximally as well, like that one. And the left vertebral artery has a grade 4 injury when it has a segmental occlusion in the mid-cervical segment. Those injuries can also be seen in the coronal plane. Here we see the distal right internal carotid artery injury with the narrowing and the pseudoaneurysm formation. We can see the segmental occlusion of the left vertebral artery, and on sagittal images we see some of those filling defects of the right vertebral artery at multiple levels. This is an example of a patient with a grade 5 vascular injury, which is very infrequent to see. Focus on the right common carotid artery. As we go up, we start seeing the internal carotid artery. It decreases in caliber severely, and then we start seeing all of this extravasation, very, very extensive extravasation of contrast that extends all the way to the oral cavity. On sagittal reformatted images, we can see the carotid bulb, the narrowing of the internal carotid artery, and all the extravasated blood in the tissues in the vicinity, extending all the way to the oral cavity. That patient underwent a surgical ligation of the right internal carotid artery. This is a cerebral angiogram 12 days later, an injection on the right common carotid artery, and here we can see opacification of the external carotid branches, occipital, superficial temporal, and internal maxillary artery. And as we scroll forward, we can see that the ophthalmic artery is sending some collaterals. The ophthalmic artery here is sending collaterals to opacify the internal carotid artery. And as we can see, the rest of the internal carotid artery, all of the MCA branches and even the segments at the skull base are opacifying retrogradely. It is amazing that this patient got away with a very small infarct in the right carotid nucleus, but not more than that after that terrible vascular injury. The next subset of patients that we analyze on CTA are the patients with a stroke. On them, we analyze the characteristics of atherosclerosis, thromboembolism, dissection, inflammatory arteriopathy, and carotid webs. This is a patient with very severe atherosclerosis disease. We can see that the brachiocephalic artery is occluded from its origin in the aortic arch, but then more distally we can see that there is filling of the right subclavian artery. Let's continue on the right common carotid artery, which is occluded, and we get to the area of the carotid bulb where we see dense atherosclerotic plaques, some external carotid branches, and now the internal carotid artery is filling with a small caliber, but is being reconstituted by external carotid branches. Now let's go down on the left internal carotid artery, and we can see that there is severe atherosclerosis disease at that bifurcation. So we can see the lumen of the vessel here, we can see non-calcified plaque at the periphery, and we can see heavily calcified plaque more inferiorly. These stenosis are difficult to measure because there is overlap between the densities of the calcified plaque and the lumen of the vessel. However, the reformated images can be helpful. One more thing that I want to show you on this patient is the physiology with the vertebral arteries. The left vertebral artery is originating from the aortic arch. It fills all the way to the intracranial circulation, and then it gives retrograde opacification of the right vertebral artery. So this vertebral artery is opacified from the top down, and then as it gets to the subclavian artery, it provides the circulation for the right arm. This is the kind of patient that would have a subclavian steal syndrome. That information about the physiology of the vertebral arteries was inferred from the previous CTA, but we do have an injection of the aortic arch that was done the following day, and we can see the opacification of the left vertebral artery, which is filling antegradely. It goes to the basilar artery, and then we see retrograde opacification of the right vertebral artery, and as that progresses, it goes all the way to the right subclavian artery. This is an example of a carotid dissection. Focus on the left internal carotid artery. As we scroll up, we see that at the level of the carotid bulb, the lumen of the artery is opacifying only peripherally in a crescent shape with a filling defect that is lateral. As we advance, the filling defect moves posteriorly and the crescent shaped lumen moves anteriorly, and then as we go up, it looks like the crescent shaped lumen moves posteriorly and the filling defect is anterior. And at this level, we can see that the lumen is split in two, opacification on both sides of that more linear filling defect. That's an intimal flap. Distally, the artery continues to have that peripheral filling defect that changes location. It rotates around the lumen of the vessel. The coronal reformated image shows different views of all of those filling defects that we see around the lumen of the vessel, and in some areas it looks like a sagittal filling defect that is splitting the lumen in two. For intracranial vascular occlusion, follow your regular pattern of looking at one vessel at a time. On this example, we follow the left MCA, and we notice that there is an abrupt cutoff of that vessel with distal lack of opacification. We still see the ghost of some of those non-opacified vessels, but when we compare to the right, there are fewer opacified branches on the left as on the right. The MIPS are great to show these occlusions because they show you multiple branches of the vessel at a time. So you can see that abrupt cutoff of the left MCA, and you can see the paucity of peripheral branches more distally. The sagittal MIPS can be very useful to compare the number of branches on one MCA. As you scroll across the midline to the other side, you will see that the number of opacified branches on the other side is significantly different. Carotid webs are a form of fibromuscular dysplasia that result in a shelf-like projection of the intima into the lumen of the proximal cervical internal carotid artery without calcification. They are seen in young patients with unilateral stroke. Here we see an example of what we would see on a CTA. On the sagittal MIP, we see a linear, very skinny filling defect without atherosclerosis, and then we can see that similar linear, thin filling defect in the medial aspect of the carotid bulb. This concludes our analysis of CTA interpretation. I have a few take-home points for you. First of all, analyze your source images carefully. They contain all the information that is going to be reformatted. window the images so you can see the arterial wall and the surrounding tissues. That is very useful when you're going to detect dissections and atherosclerosis. And third, be aware of what each set of images is destined for. The MIP reconstruction images will show thicker portions of the parenchyma with long segments of the vessels, and they are very good to see narrowing, irregularity, occlusion, and branching points. On the other hand, the multiplanar reformatted images are the equivalent of your source axial images, but they are in the coronal and in the sagittal plane, and they will allow you to see detail of small structures in skull base and the craniocervical junction. I hope you have enjoyed this material and give us any feedback.